have Carolina Arteaga from the University of Toronto presenting work that is joint with Vicky Barone. And for those of you who have not been to EHEC before, welcome. To those returning, it's always nice to see you again. And if you have questions, please ask your questions, but put them in the Zoom chat function. And some of them, I know that Vicky Barone will be able to might respond to some of them, but others I will be sort of moderating and passing on to Carolina. So please do use that. She has indicated that she wants questions and she likes questions. So with that, I will pass it along. Take it away, Carolina.
Thank you so much, Ezra and all of the team for having us. So this is called the Opioid Epidemic, Causes and Consequences. Joint work with Victoria Barone, who is a PhD student at UCLA going on the market next year and who is a fantastic co-author. Okay, so overdose deaths involving opioids have increased dramatically in the US in the past 20 years, and they have reached almost 250,000 people. However, the opioid epidemic doesn't stop there, but it has also been linked to an increase in disability claims, worsening of birth outcomes, and a record number of children living in foster care due to the drug abuse of their parents. However, understanding what if something is the cause of the opioid epidemic is really challenging because on one side, deteriorating socioeconomic conditions could be the cause of the increased demand for opioids, but also the initial cause for subsequent negative outcomes. However, we cannot forget that at this time there were major supply changes. The access to very potent opioids increased dramatically. There were significant changes in physicians' prescription attitudes. And there was a very aggressive marketing of pharmaceuticals around prescription opioids. So what this is going to mean is that in equilibrium, the variation that we see in the cross-section and over time is going to be a function the variation in the level of prescription opioids is going to be a function of the incidence of pain in the population, for example, which could be a source of negative selection. But it has also been documented that it's a function of actual access to the healthcare system and things like the number of physicians per capita, which could also be thought of as a positive selection into across space. So this is why understanding both the causes and the consequences of the opioid epidemic is challenging. So what we're going to do in this paper is that we're going to propose a novel instrumental variable based on Purdue Pharma's marketing strategy. Specifically, we studied recently unsealed court records from state litigation against Purdue Pharma, mostly from Kentucky and Oklahoma. And we're going to talk about this extensively, but the core of the idea is that we're going to exploit the fact that at the time of launch of OxyContin, the promotion of this drug, the marketing of this drug was targeted to the cancer market. So that's going to allow us to link the pharmaceutical marketing practices to the distribution of opioids. So we're going to be able to assess what's the role of supply side factors. And then this is also going to allow us to use this initial variation as an instrument to get at the causal effect of the opioid epidemic on things like drug-related mortality, but also disability, SNP, birth outcomes, and fertility. So what do we find? Well, first, we find that there's a very strong connection from what Purdue Pharma initially was trying to do from their initial marketing practices in terms of cancer targeting. So commuting zones with the highest cancer incidence at the time of launch of OxyContin received around 2 doses per capita more than commuting zones with lower cancer incidence. And this accounts to around 64% of the average change from 1999 to 2018. So there is a very strong relationship between the initial targeting and the initial targeting of Purdue Pharma and the future distribution of opioids, prescription opioids. And then we also find that moving from the 25th to the 75th percentile of the opioid distribution is going to increase the deaths from prescription opioids by around 90% and the deaths from all opioids by around 40%. And this corresponds to around 200,000 deaths. However, we do not find evidence that there is increased mortality in other types of deaths of despair. So looking at things like suicide or alcohol-related deaths. We find that there is a very strong and positive effect in terms of increased claims from SNAP and disability. So 57% for SNAP and around 50 and 75% in SSI or SSDI. And in general, we see a worsening of birth outcomes, so decreases in pregnancy duration, birth weight, and health at birth. However, we don't see an overall change in infant mortality. And finally, the last result is that we see an increase in fertility rates that is mostly driven by younger women. And we think that this may be offsetting the changes in the negative outcomes in terms of birth outcomes of kids. So what's our contribution to the literature? Well, our first contribution is on the literature on the origin of the opioid epidemic. So there's some papers that look at the demand side of the origin and other papers that look at the supply side. Here we're contributing with new evidence that links OxyContin's marketing to the rise in supply and mortality from opioids. So another piece of evidence on the supply side. We're also contributing to the literature that looks at the effects of the opioid epidemic. So there is other work that looks at the effect in terms of mortality, disability, and maternal and birth outcomes. Here, we're going to be the first attempt to look at all of these outcomes comprehensively. And also many of this work is looking indirectly at the effect of the opioid epidemic, evaluating things like PDMP, like different policies that try to curb the opioid epidemic, but not directly the effect of the opioid epidemic. So we're going to provide some direct causal evidence on a comprehensive group of outcomes. Okay, so that was my introduction. The rest of the talk, I'm going to give you more context on the opioid epidemic. And then we're going to spend some time talking about the marketing practices of Purdue Pharma at the beginning, during the mid-1990s. Then I'll talk about our data and our empirical strategies and results. Okay, so opioids refers to a class of a large number of drugs that can be both natural, synthetic, or synthetic. So natural opioids are things like heroin and morphine, and synthetic or semi-synthetic opioids are things like oxycodone or fentanyl. They all vary in potency, but they're all pharmacologically very similar. And what's different about opioids, or what's scary about opioids, is that they're highly addictive, and that there is a very rapid progression to physiological dependence with tolerance and withdrawal. And what is very tricky about this is that this physical dependence can occur at prescribed doses and within short periods of time. So you don't need to be consuming opioids beyond what it's been medicated in order to develop dependency and withdrawal. And the symptoms around these withdrawal are very debilitating. So they include pain, chills, diarrhea, nausea, intense craving. So something very complicated. Now, prescription opioids are mostly used to treat moderate to severe pain. Opioid prescriptions peaked in 2012 when there were over 80 prescriptions per 100 people in the US. But even after this decline, still in 2017, 35% of adults use opioids painkillers, and between 4 and 5% of adults in the US misuse prescription opioids. So there is a very widespread use and misuse of prescription opioids even today. And this is worrisome because legitimate prescription of opioids have been linked to long-term dependency, to the increased probability of overdosing in the family, and to the start of future use of heroin and other illegal drugs. Now, one thing that is important to note is that the increase, this positive trend in the use of opioids is mostly driven by what is happening in oxycodone. So what we have here is the distribution of the different prescription opioids. And what we see in orange is that oxycodone is really the largest player in this story. Okay, so let's dig into the story of OxyContin and the marketing from Purdue Pharma. So OxyContin is a prescription opioid, pain reliever from Purdue Pharma, whose active ingredient is oxycodone, so the yellow area from the previous graph. And what was new and why was this drug such a blockbuster? We think that this is the result of two things. One, the fact that there were actual technological innovation in this pill. The first of these is that this is a drug that is a single agent opioid. So it's not combined with things like ibuprofen or acetaminophen. And what this means is that there is no ceiling to how much opioids you can have in one pill, because usually the other ingredient is the one that's gonna, above a certain level, it's gonna be toxic for your body. So the fact that this is a single agent opioid means that there is no ceiling to how much opioids you can put in a pill. And the second technological innovation is that they Purdue developed extended release formulation. So now a pill is going to give you relief of pain for up until 12 hours. So before, instead of taking a pill every 6 hours or every 8 hours, now you only need to take one pill for 12 hours and you're going to have the same relief of pain. But this also means that each pill is going to have a higher concentration of opioids. So for example, to have an idea of how much this changed the access to potent opioids, before the introduction of OxyContin, the most commonly prescribed oxycodone drug was Percocet, and the typical tablet of Percocet would contain 2.5 milligrams of oxycodone, whereas the typical OxyContin drug tablet will be a tablet of 20 or 40 milligrams. So you're really multiplying by 10 or 15 the potency of each of these pills when you introduce these technological innovation. And the second reason of why was this so successful is because Purdue Pharma had a very large and motivated sales force. So they were the largest sales force in the pharmaceutical industry, and they were very well paid. So this sales force were making around $100,000 a year, and we're talking about the mid-90s, but up to $250,000 a year. And they were trained to push a message of the very low rates of addiction of opioids, and of how there was really an epidemic of untreated pain in the US, and how millions of workers in the US were going to work with unbearable amount of pain, and there was no one doing anything about that. Okay, so what is the context in which OxyContin is launched? So before this happens, we live in a world where there is stigma around the use of opioids from both patients and physicians. So opioids are typically just associated with morphine, and they're associated with a drug that is for terminal cancer or for end-of-life pain. So it has this very negative stigma around the use of opioids. And to some degree, there is untreated pain in the population, and this is also a context where there is a very low physician prescription oversight. So in this world, Purdue Pharma, with their drug MS-Contin, they are the gold standard to treat cancer pain. So they are the largest, the biggest player in that market. But it turns out that MS-Contin is expected to face generic competition starting in '96. And this is the world in which they decide to launch OxyContin. So they decide to launch OxyContin with the idea that they want this drug to take over the MS-Contin market, but they also want to expand to the larger non-cancer pain market in the future. But this is their plan, but they know that they face two major challenges. So they face the challenge of the stigma around prescribing opioids for both patients and physicians. And they also know about the challenge of the extra paperwork that prescribing opioids entail. So how are they going to address these challenges? So in terms of the stigma, well, part of this is going to be the messaging of their sales representatives, where they're just going to lie about the addiction rates of opioids. They're going to push this message of the untreated pain epidemic. They're going to push this message of pain as the fifth vital sign and as something that should be treated in itself and not as the symptom of something else. They're also going to lie about oxycodone being weaker than morphine when it is actually 50% stronger, and because they know that morphine has this personality as an end-of-life drug. So how could you prescribe oxycodone, something that is stronger for chronic pain in someone that is 20 years old? So they are going to lie about the personality, in their words, of the drug. And most importantly for us, they're going to target the cancer market. And they're going to do this because they know that patients and physicians in that market are already used to prescribing and taking opioids. So for them, there's not going to be this stigma around the prescription of opioids. In terms of paperwork, they're also going to target it also makes sense to target the cancer market because, again, they're already doing this with their use of MS-Contin. They're going to target pharmacies who are serving the cancer pain market because of these same things. And they're going to also target non-tropicate states where it is easier to prescribe opioids. And this is something that Avi, Alpert, and co-authors also study. So now this is how they're planning to introduce the drug, but they always have in mind that this is not where they plan to stop. It is always very clear for them that they want to expand to the larger market of the non-cancer pain market. So in the phase 2 of their marketing plans, they expand promotion to primary care physicians and family doctors. However, they're going to focus disproportionately on top prescribers. And what this means is that this is going to create a path dependency that in all of those places where you targeted first, and by definition, those places are prescribing more, then they're going to receive a disproportionate amount of marketing because they decide to target top prescribers disproportionately. Okay.
Carolina?
So, yes.
So there's a question in the chat. I think it's probably a good point to jump in with it, and also to let you have a sip of water. What did Purdue know about the addictiveness of OxyContin based off of what has been revealed from the documents that you reviewed?
So they were citing a comment on a journal that said that it was less than 1%, but these number didn't have any like scientific support. So this is what they had in their in all of their products, and this is what they were saying to physicians, but there is really no support for no real science behind that number. And even if that number was correct, 1% is a lot, even when you're prescribing these so widespread. But yeah, they didn't want to learn about what was the addiction rates of prescription opioids, and they were just citing this number that really had no real evidence to support.
There's another question just came in about this idea of the top prescribers here that you've called out, and to what extent were top prescribers sort of in the space of the so-called pill mills? Like what's, if you thought about like Venn diagram between the pill mills and the top prescribers, maybe.
So not. This is going to happen in the future, but at the very early years we're talking about 98, 99. This is not such a big deal by then. But when they say top prescribers specifically, they are talking about the top 30% of physicians prescribing. And within that top 30, the three largest deciles, within them, they focus more on the top 10% than the top 20. So even then there is a decreasing promotional efforts, but specifically the top 30% of physicians, which they have very good data on how much everyone is prescribing and to what type of patients, when, and everything. We try to obtain these data, to buy this data, and somehow it looks like it doesn't exist, but Purdue had access to this data and was using it for their marketing plans. Okay, so next, I just want to give you some of the sites that we extracted from Purdue Pharma's team meetings. So for example, here in 94, they're saying that OxyContin tablets will be targeted at the cancer pain market. In 95, they're saying that OxyContin primary market positioning will be for cancer pain. Here it says at the time of launch, OxyContin will be marketed for cancer pain. But this last quote, I think really summarize what they were doing. So it says, the use of OxyContin in cancer patients initiated by their oncologist and then referred back to family practitioner, general physicians, blah, 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 will result in a comfort that will enable the expansion of use in chronic non-malignant pain patients also seen by the family practice specialists. So they are targeting that market, but only to make patients and physicians familiar with this new drug and to make them comfortable in so that they could then prescribe these to other type of patients. So this is what they were doing. And why they were doing this? Well, we already covered that, but in their words, they say that they find that there is not the same level of enthusiasm toward this drug for use in non-cancer pain as we identify in the cancer pain market. And there's also logistic considerations for these decisions. So they also know that pharmacies are generally reluctant to stock class 2 opioids. This was back then, this is not the case anymore. And so because of these initial targets will be the 25,000 stores who stock MS-Contin. So all of these summarize the fact that again, because of stigma, because of paperwork, they knew that they couldn't just enter the pain market in general. They knew that if they wanted to do that, they needed to start in the places where there was less trouble. So in terms of our identification, what that means is that areas with higher cancer incidence receive disproportionate amount of marketing for opioids. And Purdue's later strategy to target high prescribers creates a path dependency that is going to make this initial targeting relevant throughout the period. So this allows us, for the identification of the role of supply first, and also the causal effect of the opioid epidemic on a broad range of outcomes. Okay, so in terms of data, so our prescription opioids data comes from ARCOS, which is a data set by the DEA that tracks all prescription opioids. Our mortality data is going to come from the National Vital Statistics System. We have access to this data with geographic identifiers. So we're going to construct measures of prescription opioids mortality at the commuting zone level. And this is also going to be our measure of our instrument. So we're going to measure cancer incidence or the cancer market as cancer mortality. And this is also going to be our source for birth and maternal outcomes. And finally, our SSI and our disability and SNAP data are going to come from Social Security Administration reports and from reports from the Food and Nutrition Service. So our final database is going to be 11,800 observations, which come from 590 commuting zones over 1999 until 2018. And we're only going to look at commuting zones that have a population over 25,000 because many of our outcomes are low probability events, but we can play around with this threshold and that doesn't really vary our results. And this also includes over 98% of the population. So here are some descriptive statistics that I'm going to skip for now, but we can come back to them if there is any specific question. Okay, so our empirical strategy. So again, we're going to exploit Purdue's initial cancer targeting for the promotion of opioids to first estimate the role of supply and then estimate the causal effects of the epidemic. So in order for this to make sense, first I need to show you some evidence that that cancer mortality in the mid-90s is actually something relevant for the future prescription of the future supply of opioids. So that's related to the relevance or the first stage of our exercise. And then, well, we're going to use mid-90s cancer mortality as an instrument, and of course, this is not something that is exogenous. So I need to show you some evidence that places that differ on their cancer mortality are not places that are going on different trends. So I'm going to show you some evidence of that, and then also looking at the pre-trends of like before the introduction of OxyContin, how do these places look like? And then some direct evidence of like what is happening in terms of our outcomes as a function of mid-90s cancer mortality. Okay, so in terms of the first stage, so this is a plot of just the raw data. So here we're splitting commuting zones in those that have the highest quartile of incidence of cancer, and that's going to be the solid line. And the dashed line is going to be the commuting zones that have the bottom quartile incidence of cancer pain, of cancer mortality. And so what we see here is that, so our data starts in 97, this is where the ARCUS data starts. We see that even though all of these commuting zones are starting from very low levels of prescription opioids in 97, there is a clear divergence in terms of how much prescription opioids the high cancer commuting zones are receiving relative to everyone else. And it's not that cancer is exploding in these places. So here what we see is the incidence of cancer mortality between these two regions, and we actually see that yes, this is higher cancer mortality than this, but it's a relationship that is stable. But from this graph, it is clear that these places are on a very different trajectory.
Carolina?
So, yes.
So there, I just want to jump in because there are a few questions and that I think are sort of all related to what you were just showing us and what I think you're going to show, and maybe like this slide and possibly the next slide, but maybe it might be easier to sort of think about them collectively because I think they're all touching on some similar things. So one question is about the targeting of the marketing and to what extent geography of marketing is determined by where the physicians and maybe the oncologists specifically are located versus where patients are actually located, because there's a lot more lumpiness of where specialists are located presumably. Another question is, to what extent does cancer mortality map to cancer incidence, and thinking about how some cancers have over time become more treatable, so which could create sort of a wedge between the mortality and the incidence. So I'm trying to think. I think that covers most of the most of the questions for the moment. There's one other, but I think we'll get to that one later. Yeah.
Okay. So about the second one, that in terms of like what we want to measure is something related to cancer patients. So the patients that were actually receiving MS-Contin. That's something that is hard to get. There are some measures of cancer incidence, but they're not going to be as granular as we need them to be. And then we also have the problem of there's also variation in the diagnosis, like when is this being diagnosed early, late, or is it not diagnosed at all? So it also has that additional problem. So we think that cancer mortality is something that first is available at a very granular level. It's less prone to be a function of diagnosis, and that's something important. But we do want to play around more in terms of, as of now, this is all cancer mortality. We do want to play around more with cancer that is less driven by behavior, cancer that is less driven by occupational choice. But that's something that we haven't done yet, but we want to do. The first question, sorry, I forgot.
The first question was...
it was kind of like the distribution of the market.
Yes.
So, I mean, one thing that it's important, and like we're not, even though a lot of our data could be at the county level, which is a finer unit of a geographic unit, we want to think about commuting zones, but because we're thinking of like the market of doctors or the health market that you have access to, that is often something larger than your specific county. So that's how we're thinking about that market as the place in which I can have access to a doctor and a hospital. we do, in terms of like how much of this is maybe driven by density, we have additional regressions in which we control directly by population density. But I don't know if there are other suggestions of maybe I could go back to show you some maps. So for example, this is the distribution of cancer mortality. White is that is not in the sample. And this is the distribution of, of prescription opioids, the prescription opioids per capita. And I haven't gotten there, but we will control by geographic variables such like race, but most importantly age, which is going to be a very important determinant of cancer mortality. So that's going to be part of the controls. Okay, so we were here, and now, so in terms of like what's the regression form, that it's actually going to be our first stage in the paper. So this is going to be our column number 5. But what I'm doing here is regressing the change in prescription opioids per capita as a function of cancer mortality rate in the mid-90s at the time of launch of OxyContin. And what we see, and as we go from the first to the 5th column, we're adding controls and fixed effect and state year fixed effects. And what we see is that there is a very strong and stable positive relationship between cancer mortality in the mid-90s and future shipments of prescription opioids. So this is going to be our first stage. Now, okay, I need to now move on to the exogeneity and the exclusion restriction discussion. So what we're doing in this table is, well, what if we move to the pre-period? So before the launch of OxyContin, what if we just do the kind of like the same exercise that we're doing in the post-period? Let's just take cancer mortality lagged, but this is going to be 89-90 because that's when our data starts. And let's see if that lag cancer mortality predicts things that we care about, so economic and socioeconomic variables, and also our outcomes. And what we see here is that that's really not related. Here, I have to say that we're controlling by the same things that we're controlling in our main specification. So demographic controls are going to be there. But the point that we want to make here is that places that have higher mortality, lagged mortality, are not places that are on a differential trend in terms of income or education or deaths from opioids or infant mortality rate or SNAP or SSDI. So in the pre-period, it doesn't look like your variation of cancer mortality puts you on a differential path. Now,
Carolina, one very quick question. Have you thought about looking at smoking rates as in this check?
Yes. So we have some data. We don't have that for every year, but yeah, we can add that maybe just for when it is available. Yes. Okay, so now what I want to show you here is first, let's look at the pre-trends. So how does the coefficient on cancer, on mid-90s cancer mortality affects our different outcome variables? And what we see is that before the introduction of OxyContin, there is really no relationship between cancer, mid-90s cancer mortality and prescription opioids or any all opioid mortality. Here is what if we wanted to look at the raw data. So this is a similar graph to what I was showing you in terms of our first stage. So let's split commuting zones into high and low mortality rate groups. And we see that there is really not a lot of difference between high and low cancer places in terms of their opioids mortality before or any opioid mortality, prescription opioid or any opioid mortality before. But then after the introduction of OxyContin, there is a very large wedge between these two regions. So this is the raw data. This is in regression form. And this is for main outcomes, but this is also for the rest of our outcomes. So in general, we don't see any pre-trends in terms of infant mortality or other type of mortality, deaths of despair, birth weight, SNAP, and fertility rate. But now, so that was on the pre-trends side. Now, in terms of like how to visually see the reduced form, we can also do that just by looking at the right hand, the data to the right of this dashed line. And what we see here is that as time passes after the introduction of OxyContin, we start to see a very strong relationship in terms of how predictive cancer mortality in the mid-90s is to predict prescription opioids mortality. So this is what we see here, and this is what we see here. So now we're ready to run our regression. So this is how our first stage is going to be. So basically, we're just instrumenting the change of prescription opioids in committing zone C at time t with mid-90s cancer mortality. And here we're going to control for things like contemporaneous changes in cancer mortality and demographic so Ray, Hispanic, Black, and female and age groups. So demographic variables are going to be here, and our preferred specification is going to have state year fixed effects. So I think I said everything here. Okay, so our results. So if we're going to look at prescription opioids mortality rates, here we see that there is a very strong positive relationship between prescription opioids per capita and prescription opioids mortality. Interestingly, these numbers, both for prescription opioids and all opioids, in the IV are larger than what you see in the OLS. So this is a sign of some positive selection in the OLS. Could be driven by things like places that have a better access to healthcare and more physicians per capita are places where the opioid epidemic driven by our instrument is strongest. I'm showing here our standard errors clustered at the committing zone, but also the p-value from the Anderson-Rubin test. And also what this is we're referencing the recent Lee et al. Paper that says that you need to adjust your inference as a function of the strength of your first stage. So these are adjusted standard errors, but in general, that doesn't change the level of significance. I mean, it does, but doesn't change the stars of our estimates. And what we see here is this is how we'd like to interpret our estimates. So moving from the 25th to the 75th percentile of the opioid distribution increases prescription opioid mortality by 89% and all opioid mortality by 39%. And this, okay. So other mortality outcomes. So if we were to look at all-cause mortality, we don't see much going on. If we were to look at deaths of despair, so the aggregate measure, we see something, but is much, much weaker than what we were finding before. And that's the combination of actually a zero, but also or a negative effect here in terms of suicide, and a very, very weak effect here in terms of alcohol and liver diseases. So what we see here is that this is causing excess deaths, but they're specifically coming from poisoning from prescription opioids or from any opioids, not other types of deaths. Now, in terms of social assistance, we find very large positive, well, not positive, but like positive sign effects on claims from SSDI, SSI, and SNAP. So the effect size, so again, going from the 25th to the 75th percentile, increases substantially the claims from SSDI, SSI, and SNAP. These are very, very large numbers. In terms of birth and maternal outcomes, so first, we don't see any effect in terms of infant mortality. So this is a very well estimated zero. However, in terms of health at birth, we do see that there is a general worsening of these health indicators, even when some of them are not statistically significant, they're borderline insignificant, and they're all pointing towards deterioration of health at birth. So birth weight is going down. The share that is low birth weight is not statistically significant, but close to being statistically significant. That's going down. Preterm birth, The Apgar score is lower for birth, but also the Apgar score of infant fatalities is higher. So saying that healthier infants died. So all of these points to a general deterioration of birth outcomes. And we think that this might be mitigated by this increase in fertility rate that actually comes from a combination of a large increase in those 25, between 25 and 29, and a decrease from those over 35. So it can be that this change in the composition of mothers is kind of offsetting the effect, some of the deterioration during pregnancy and during birth that we're seeing. And this is analogous to what we were seeing before, that there is a reduction in the duration of pregnancies. Okay, so in terms of heterogeneity, we find that in terms of mortality from opioids, most of that mortality is coming from young people, so those under 50, and also particularly from whites. And we find that this, even as the nature of the opioid epidemic has changed as a function of like what is being mostly abused, from prescription opioids to heroin, from fentanyl to fentanyl, there is still a strong relationship between this mid-90s cancer mortality along these three different waves of the opioid epidemic. Although if we were to look at the first stage is stronger during that first phase, which makes sense because that's specifically what Purdue Pharma is directly affecting. Did I skip one? No, okay. So one placebo test. So our instrument here is going to be cancer mortality during the mid-90s. So a very natural placebo is, well, what if we just were to choose other type of mortality that has potentially as much endogeneity as cancer mortality, but it doesn't have the link that is coming from Purdue's internal documents. So that's a complicated, it's a natural placebo, but it's actually harder than one may think, because all of these risks are very correlated. So the incidence of cancer mortality is very correlated to the incidence of cardiovascular disease. But still, if we were to do that type of exercise and we were to instrument prescription opioids per capita by mortality from cardiovascular disease in the mid-90s or transit accidents in the mid-90s, there is no such positive relationship. So this only arises in the context of cancer mortality. And if we were to control for these mid-90s mortality in our first stage is still going to be positive and strong. So we do another set of robustness checks. So ultimately, our instrument is kind of a shift share instrument, where where our shares is going to be the cancer mortality in the mid-90s, and we could construct a shift as the future growth in prescription opioids. If we were to do that, our results are quantitatively indistinguishable. They're different maybe at the fourth decimal, but they're really the same. We chose not to do that just to stress the fact that the variation that we really are using is just this mid-90s cancer mortality. But if that's your preferred specification, it's really very similar. Referring to the previous question, we add population size controls to the first stage estimation. That doesn't change much, in thinking that maybe this is driven by large places where the density of doctors and physicians is different. That doesn't really change anything. We also have this exercise where we take one state outside at a time. The results are not driven by any specific state. And we actually find that the first stage is strong both in triplicate and non-triplicate states. Is actually stronger in triplicate status states. And it kind of makes sense because in those places, it makes sense to even do a more targeted marketing strategy. We also have additional measures of opioid supply. So here in our main specification, we're looking at all forms of prescription opioids, but really OxyContin is about oxycodone. So if we were to just focus on oxycodone, things will be very similar. Also, there is some measurement issues around how to count opioid-related deaths. We have different measures of how to do this, and there's also very similar. And then lastly here, we have alternative sample restrictions on what's the minimum size of committing zones that make it into our sample that also is not driving the effects. So I'm a bit early, but I think that's fine. So in terms of policy implications and conclusions, so first, we document that the marketing and promotion by pharmaceuticals ignited the opioid epidemic. So in this paper, we can link specifically what was the plan of the marketing plan of Purdue Pharma, how that materialized into the distribution of opioids, and how that materialized into deaths from opioids. Not only that, but also increased demand from SNAP, SSDI, and SSI, general deterioration of birth outcomes, and increased fertility. In terms of policy implications, our results have, we think, direct policy implications regarding the desirability of promotional efforts by pharmaceutical companies that target physicians, pharmacists, and patients, specifically by documenting the devastating, far-reaching consequences of aggressive and deceitful marketing. So we think that it's very natural to think that there should be more done in terms of monitoring, limiting, disclosing promotional efforts by pharmaceuticals. Even though there's been a trend towards this, there's definitely more than can be done. We also think that the risk of prescribing opioids varies substantially by age and by diagnosis. And this is something that is not incorporated in how hard or how easy it is to prescribe opioids. So we think that this is also something that could be implemented, and it's very easy. And lastly, in this sounds kind of obvious, but when you study the opioid epidemic, it's really frustrating to see how many of these things could have been stopped. And if you have drug abuse reporting system, this is we can prevent this from growing or happening again. So this is it. Thank you so much.
Thank you, Carolina. So I think we've covered the questions that came in, and Vicky has also been on top of answering questions. One, since we I think have a little bit of time, that I saw Vicky responded to was a question about, so at the heart of the story of your instrument is basically this, it seems like there's like this implicit almost like spillover of promotional practices focused on cancer and presumably oncologists, so that patients then are seen by general practitioners who are then expanding their own use. And what can you say, or what do you think about, like, what do you know about the extent to which cancer patients that would have been really the targets of this promotion were actually, like, how frequently were they actually seeing their general practitioners, such that, like, we think that that would be a really strong mechanism behind the overall expansion of opioids in these markets?
I mean, one thing is we're not saying that they're getting at the cancer patients through their physicians, their general practitioners. They are already getting at the cancer patients the way that they were getting at them before with their oncologists, and the idea is to expand to the non-cancer patients. Mm-hmm. But we think that there is also a valid point about, I mean, ultimately, this is a very successful drug in controlling pain. And to the extent that living without pain improves your overall well-being, this could be beneficial to these cancer patients. We don't see effects in other type of mortality. And of course, it's kind of weird to look at effects in future cancer mortality when that's your instrument. But we don't see, like, we cannot rule out positive effects for some part of the population as, like, their pain management improved, but we don't see positive effects for sure. And in general, what we do see is that most of the deaths are coming from the younger population, and most of mortality and most of cancer mortality is really concentrated in those over 65. And in most of our results, we actually don't find statistically significant effect for those over 50. So we do know that the negative effect is not happening in the cancer population, it's happening in the non-cancer population, in the younger population. But we cannot also say that there was a positive effect for the cancer or for the older population.
Yeah. Do you have just a sense of just like how frequently cancer patients are seeing their non-cancer general practitioners altogether? Like, if you're a cancer patient, like what share of your care is really the specialized oncology care, and how much they take over your entire healthcare versus you remain still going to a general practitioner altogether?
No, we haven't looked at the data, but that's something that we definitely can characterize better. Yes.
Thanks. So there have been a bunch of questions coming in, so I just need a second here to look at them. One question: how is marketing or spread of OxyContin different in different countries, and is this experience widespread, or is this pretty unique to the United States?
So,
and also, what are other, like, you just, like, I think there's a question which is, what are the other advertising strategies that are relevant here?
So I mean, in general, there is, to some extent, an opioid epidemic in many developed countries, not by any means to the extent of what happened in the US. And I mean, this is more speculative because I haven't seen the data, but my feeling is that the amount of resources in terms of money, but also time, of like how much time pharmaceuticals companies take away from physicians is much, much higher in the US than in other places. So in general, pharmaceutical promotion, I would say, is much higher in the US than in other places. So there has been an epidemic, to like summarize, but not to the extent of what happened in the US. Okay. And part of that, I think, is, but we can document that for sure better in the paper.
Okay. Vicky is so quick on the chat that she's covering many of the questions that come in. And I'm trying to say, and Vicky, you actually might, at this point, might have a better sense of whether there's anything that I have neglected to ask, or things that you would want to jump in with a response if you want to unmute.
Yeah, great questioners. I think, so there were a couple of questions about the data that we're using. I think that we addressed those. I think that the very interesting one was like, what are other advertising strategies that is like not only direct to, because I have a comment on direct to consumer strategies that were very used by Purdue Pharma and other strategies. Maybe here is a good point to clarify that Purdue Pharma strategy include these wild, like very used visits to physicians, but they also did other stuff to change the perception that physicians have. So for instance, they started this campaign calling pain as the fifth untreated symptom. Carolina touched on this a little bit, but maybe, Karen, if you want to expand on like the wider strategy and not only like the part of just contact one-to-one to physician, maybe that will be useful to clarify some of the questions.
Yeah, so I mean, their marketing strategies is super comprehensive and just change the way of how we see pain and change the way of how we feel about opioids. So even most of their like physician time and probably manpower was about calling and visiting physicians all the time, like multiple times a month. There was also a lot of effort in promoting in journals and conferences, just like this change of language about prescription opioids. And there could be also a discussion about, yes, it's important for pharmaceuticals to inform physicians about new drugs, but one thing is like the extensive versus the intensive margin. Like I already told you about this drug. Why do I need to call you every week to check if you've done, how are your prescription habits? So there is more to do in like what is allowed and what's not, and how much time, physicians' time can these pharmaceutical companies tax or take from physicians. I don't know if I should stop sharing screen, maybe, so we can see.
It's up to you. And yeah, I mean, I think that we've covered, there are a couple of comments that are asking about, like, you know, the extent to which you can do anything empirical about promotional spending by geography, and which may or may not be possible, but.
So we really tried, and part of like our study of the documents that we have access to from Kentucky and from Oklahoma, for example, is that for just a county, maybe we have the list of all the calls that were made to the doctors there, but if it's only from a county, there's really not going to be any variation and in terms of our instrument. So we really don't have good data of their actual promotional efforts in the 90s, like that could give us a comprehensive view of what they were doing. The open payments is coming way too late for us to, like it's still useful for many things, but in order to like really tell the story of what was happening at the beginning, it's too late for our exercise.
Well, I think that brings us to pretty much the end. I think that covers the question. So before departing, I just want to share the announcement. So our next EHEC session is going to be Wednesday, November 10th, where we will have Marit Kino-Sar presenting on the malleability of alcohol consumption evidence from migrants. Should be a terrific presentation. So we are excited for that. And let's see. Yeah, and I will just quickly echo the comment from Rosalie Picula here. Thank you, Carolina and Vicky. It's a very impressive and comprehensive paper. So thank you so much for sharing it with all of us. And thanks to everybody for tuning in. We hope to see you at the next EHEC session. And if you aren't on the mailing list, please go to ehealthecon.org and join the mailing list and tell your friends, colleagues, in-laws, students, professors even that about us, so we can continue to expand the reach of all this great research. So thanks, everybody.
Thank you so